Hello, everyone. This is Siddharth Tambar from Chicago Arthritis and Regenerative Medicine. Welcome to our weekly Wednesday live session. Today, my guest and colleague is Dr. Orlando Landrum. Welcome, Orlando.
Thank you. I appreciate it.
Orlando, so it is May 13th, 2020, smack in the middle of COVID. How are things going for you?
I think everyone is challenged right now. And I think right now we're really trying to figure out how to be able to help patients in the context of this challenge. So we've instituted a number of measures from a telemedicine standpoint, much in a similar way as I believe you guys have as well as Chicago Arthritis, to figure out how can we be able to help fill the gap? How can we be able to help provide value? And I think that there's a number of things that are out there where we're hearing different statements that we're trying to interpret the veracity and truth. But at the end of the day, what we're here to do is to try to be able to help patients be able to lead fulfilled lives and be able to decrease their pain and help them be able to be functional. So, I think to that end, one of the things that we really kind of looked at is number one, and I think both of our practices have done this, is how do we find ways to be able to make sure patients are safe no matter what? And then after that, how can we be able to make sure that we provide an option that many other places and facilities just really can't do? Whether it's really truthful that surgery has its own challenges in terms of open surgery and potential risk factors. For us, the things that we do are percutaneous. And as your viewers know, that means that we're not having to cut someone open, so that their level of risk is much less. So the question is, how can we be able to explain what are some of those options and how to get patients from point A to point B safely?
Yeah, that makes a lot of sense. The way that we've taken it is, first and foremost, we want to be available to help out folks with their chronic issues or even with their new evaluation issues when it comes to their musculoskeletal issues. And whether that is in person, whether that's over telemed, like the end result has to be the same, which is offering great patient service, great client service, offering some sense of continuity of care, and offering some sense of confidence during a time of a lot of confusion and concern, because this is definitely new and scary for a lot of people. But I think if you go into it thinking, all right, our end result is people are going to be well taken care of, then I think getting there regardless of the technology is it's just a matter of figuring out the tech. Because realistically, what we do as physicians goes beyond just a procedural element. It's a lot of just offering confidence, security, and guidance, even though everything is kind of kerflooey right now, right? I mean, realistically, I say this half jokingly, but kind of truth as well, which is there are like 8 billion people in the world who all know the same 20 things about COVID right now. Right. But the difference from a physician's standpoint, we have at least an understanding of basic principles when it comes to how to keep people safe, how to guide them through this time, and how to help manage a lot of their issues that they're dealing with. Because, as I'm doing a lot more telemed and these kind of interactions, like I'm starting to notice neck pain myself, right? Just hunched over throughout the day. And it's great to have colleagues such as yourself who have a high level of skill when it comes to pain management, and especially when it comes to spine, that can help guide and help us out at this time.
Yeah, I think that neck piece is starting to be something that is pretty prevalent throughout. It hasn't just been with the context of telemedicine, but, there's that quote unquote variant that's called text neck, that's been out there for a while with those muscle strains from just being on the phone and having that bent posture, which isn't necessarily optimal. And then whether it leads to other degenerative things or things that both myself and you can be able to kind of help with.
Right, for sure. Let's talk about neck issues. Number one, let's take the real basics. All right, I mean, like getting real down basic before we start talking about more advanced, cutting edge, complicated things. But if me as your patient says, Dr. Landrum, my neck is killing me. I'm sitting in front of this iPad, this laptop 24/7. What can I do to help manage some of this neck and shoulder pain that I'm developing from my occupation? Because I really don't want to keep on taking narcotics and anti-inflammatory meds. Help me out, please.
So I think we have a very kind of similar process about how we'll go after things like this. And the first is, we don't want to make the assumption that what presents itself in an obvious fashion is the only thing that we need to identify and evaluate. So what we'll do is do a really comprehensive evaluation and physical to be able to get some clarity and understanding. I mean, I think most people would say, if they went to their grandmother's kitchen, their grandmother's kitchen would probably say, oh, well, it's probably because you're bent over working so hard. You just need to relax and massage it. But we don't want to take that obvious option as the only option, right? So what we want to do is to really get some insight about, okay, is that pain there constantly? Does it ever deviate? Is it intermittent in nature? And if it is intermittent in nature, when does it seem like it's worse? And those things make a difference, right? So let's say that the aspect of the postural piece with the computer and the iPad, you're off on the weekend in theory, and you're not really bent over quite as much. Is the pain better on those days? And so those would be the things that we'd kind of engage with and want to ask you either in person or virtually to kind of get some further clarity. And then the other things that we want to know is, so I'm assuming, and this might be a bit of an assumption, but clearly this pain has probably been debilitating enough that you've tried some other things to try to alleviate it. What are those things?
Yeah, wonderful. If you're talking about me specifically, okay. So right. I guess I continue to do my workouts at home. I haven't been to physical therapy in years, and I'm propping up more pillows behind my head as I'm sleeping now, and I'm still getting some soreness at the end of the day.
Sure. So, I think that there's a lot of things that are going on with that. And I think if we look at from kind of a potential decondition type state, I think that there's some things that we can do. And one of the things that you mentioned right off the bat was the aspect of therapy and having some time away from it. And without doing an exam at the moment or even going into further, which is what we would do if we really were kind of fully fleshing this out. I think that aspect of exercise and activity and really being able to make sure that those muscles are engaged and that connection that's there is robust, I think those are going to be kind of our starting points for pretty much every patient.
For sure. That makes a lot of sense. So how are you handling the physical exam component for telemedicine? I've had an interesting experience with telemedicine, and you've been using telemedicine for years. Like you were sort of early into using the technology, I think before a lot of us were. How do you manage the physical exam component in, let's say, number one, let's say someone that you know well, right? Like you've treated them in the past. And number two would be someone who you don't know well, who's relatively new to you. How do you manage some of those things?
So the thing that I would say is, number one, in terms of dealing with physical, the main thing that's going to be lacking is the aspect of true palpation. To what do you feel underneath your fingertips? What's the tactile clue that you get back from touch, right? But excluding that, I think it's the aspect and the blend of using history with common sense, right? This is the time where, to be quite frank, and I think many docs are able to do this, but I think they just have to kind of think outside the box a little bit, where you got to come down from the ivory white tower and say, all right, how can I make this work with what I got? To kind of reference an old school, I guess now kind of TV show is, how can I MacGyver this, right? So one of the things that we want to know is the aspect of strength to start off with, right? With whichever different context you're talking about, right? So because you can't have them apply pressure directly to you does not mean they can't apply pressure to an inanimate object. So what does that person have in their household, right? Do you have a gallon of milk? Do you have some soup cans? Do you have those type of things to be able to see how well they're able to lift and maneuver and move that arm, not just in terms of their own body, but when they have some weight that's associated with it. Let's see full range of motion. And what you have to do is say, okay, You're using your phone more than likely. We know that's about the case in about 60% of individuals and patients, right? So, and only another like 30-40% are using laptops and tablets, right? So in order to get the phone, first of all, you got to get it positioned, and you got to get like some books to kind of stack it, because you can't hold it in one arm unless you got impossibly long arms in order to really be able to see different parts of the body. So then once you have that position, then you can see full range of motion. You can be able to see that aspect and mobility that's in place. And then you can talk people through it. And for the patients that have followed me regularly, to be quite frank, they were ready for telemedicine because we've been doing it. And they're like, hey, you know, I understand that I don't get to be there in staff, and rather in person with the staff and with you, but I know you can talk us through it. And the convenience and the safety of being able to do this is key right now. So yeah. I think how you use common sense and how you can be down to earth and really be able to engender a connection to say, you know what, let's work with what you got in order to get to where we need to be.
Dr. Landrum, you had me sold when you said MacGyver. All right. So, I mean, I used to love that show when I was younger. And the interesting thing is that there's actually, I think now that we all have so much more time at home, I think I saw like a modern day version of MacGyver. There's like a reboot of it.
Oh, really?
And I only saw like 15 minutes and I lost interest. There was something about the original MacGyver that just was more authentic, something about the 80s, right? Exactly. I mean, a guy taking a pocket knife and like, you know, creating a jet plane, you know, like just that just seemed to make sense. Yeah. But the modern day version doesn't quite hit as well. But it sounds like what you're saying is you're using medical intelligence and experience with some common sense and utilizing the tech that's available and having a relationship or engagement with that person over this sort of technology where you can still get a significant amount of information just based on active range of motion and some limited but still helpful examination maneuvers, which I agree with you goes a long way to figuring out a lot and can get people on the right path to sort of figuring out what needs to be done and giving them some kind of plan. I think we're at a moment right now where clinics are starting to open up more expansively, where you can still use telehealth as sort of an initial conduit and then sort of figure out if somebody needs to come in for a little bit more diagnostics or treatment as well, which I think is a smart way to use it, not only now, maybe that's how it should be going forward.
Yeah, I definitely agree with that latter portion. You know, I think not only can we do strength and range of motion, but you also can be able to tell if someone has a neurologic or sensory deficit to an extent as well. You know, if you have a family member that's there and you can instruct them, you can be able to even figure out what the reflex response happens to be too. Yeah. So I think that you can get a more robust exam than what most people think. But when we talk about technology and where things are kind of going, right now there's an Echo, spelled EKO, not ECHO, device that can be shipped to patients and it's applied to their chest. You can be able to hear and auscultate the aspect of their heart, whether they have rhythm issues, whether they have murmurs, what their pulmonary function sounds like, whether you have rattles, whether you have rails, all those type of things. And there's actually a more involved kit that's put out by Tyco, which allows you to do ophthalmoscope, otoscope, traditional things that primary care docs would kind of do. Where the burgeoning technology is now starting off is there's actually a program that's from Israel that can use your phone to be able to take and figure out your blood pressure by just the aspect of how the vascularity of your face kind of presents. It can be able to see your pulse oximetry and be able to give you the aspect of cardiac output. And so there's a number of things that are coming out from a non-invasive standpoint where I think we're only in the infancy of where telehealth kind of exists in order for us to then be able to put quantitative parameters behind the aspect of what we're getting from our history from a qualitative fashion.
That's incredible. I haven't heard of any of those things. That is really amazing. I think the other thing that's going to be happening a lot faster, in large part because of COVID-19, is how much more we're going to start using things like VR and even augmented reality in the next couple of years. I think that's probably been escalated significantly so, just because of everything that we're dealing with right now. Over this winter break, my family, we went to Los Angeles and we got a chance to go to a VR arcade, a virtual reality arcade. And it's amazing just how fast, just from the video and the audio sort of input that you get, how quickly your brain can adapt to that and sort of fill in the gaps a little bit. And that was even without any sort of tactile sense. But you could imagine a world where some kind of basic tactile sensation that could be transmitted over some kind of digital platform could give you even a little bit more from that sort of palpation sense. I think some of that's going to happen a lot faster just because of everything that we're dealing with right now. But it sounds like there's already tools available that as they start to get applied more widespread, people could start using right off the bat. That's really incredible. I almost feel like, Orlando, I almost feel like we could just have a conversation about tech in medicine, and I could just sit here and like listen to whatever is going on, because I know you're always at the cutting edge with that.
Well, I don't know about all that, but what I will tell you to piggyback on that aspect of VR. So not in traditional musculoskeletal, but in pain sense, particularly when you're talking about nerve pain, neuropathic pain, sympathetic nervous system, they've always kind of looked at to see whether there was some aspect of, can you be able to ameliorate that pain from a non-invasive standpoint, right? And so there actually is a company that's in Spain that uses VR and uses it in the context of being able to produce kind of how you use the mind-body connection. And they put you in the state of being able to have a cooling type state, because traditionally neuropathic pain, as we know, has kind of this very like burning type sensation that's in place. So they put you in a VR environment, and they've been able to measure skin galvanic response, which is indicative, so we believe, of sympathetic nervous system, and have been able to see changes that have been representative of the same type of changes you'd get from using like a spinal cord stimulator or a traditional transcranial direct current stim. So those type of things they've been able to kind of replicate from doing the VR stance, but it hasn't really taken off because there hasn't been the necessity to do so as of yet. So I do think that, how we have those little steps, there's a few steps that have already been constructed for us to be able to see what are some of the paths of how we can be able to go about doing some things that will be interesting going forward.
I think it speaks to just how fast humans adapt. I give this example for telemedicine right now. Both my parents are actually watching right now. And I can see my mom is on IG watching this. When they both are practicing physicians in Western New York. And my dad is 75 and my mom is 74. When my mom realized that she had to convert her patients to telemedicine, it took her basically 3 hours, and she converted all of her patients, figured out the tech, the billing part, the service part. She figured out everything in like 3 hours. And like she was motivated because she wanted to make sure that her patients were taken care of properly, right?
Sure.
And so I think there is something to the fact that if there's enough motivation and enough of a why, enough of a reason, as humans, we figure it out pretty fast. And I think what's great about that is the tech part is it assists you to get there, but the real driving force of the whole thing is just how do I help this person out right here in front of my face. And so whenever I hear physicians say they can't figure it out, all I can do is shake my head. I'm like what else are you doing, right? Like this is the reality. As physicians, I think our greatest skill is in our ability to adapt to the circumstances, whether that's telemed or more challenging circumstances. Realistically, we figure out a way to add value regardless. Okay, so let's say we've done some evaluation. Next steps for my sort of posture, my increased pain from my neck. What are our next steps as someone who, let's say, has done absolutely nothing except complain to his wife for the last 3 weeks about his neck pain? What are my next steps?
Well, the first is to make sure that your wife doesn't do something to you. So we want to make sure we can clarify that complaining and how to be able to address that. But thereafter, I think the pieces that we really want to kind of have a divide of is, first, is this acute pain or is it chronic? And it sounds like to me this has been going on for a period of time. So now we need to kind of start evaluating that a little bit, right? So if it was acute, then we might talk about doing some other type of not necessarily aggressive, maybe some other exercise, maybe some therapy, potentially maybe an analgesic of some sort to see if we can be able to make you feel better, right? But assuming that this is chronic and this is much more debilitating, the thing that we want to see is, so are there certain points that really can elicit this pain? Is it worse when you have extension? Is it worse when you have flexion? Are you having any type of radicular symptoms, meaning is it going down into the shoulders or into the arms? Are you having any deficits or sensory changes that are in place? So those are things that I'd be asking right off the bat. The things that I think are a little bit more obscure or occult are things of, does it go up into the head? Are you having any headaches? Are you having any vision changes? Is it affecting the dental component? Does it cause you any problems when you chew? All those type of things would be kind of critical. You mentioned previously that you had some changes with the pillows and sleep and those type of things. What I'd be curious about is, so what's your flexion? What's your extension? How do you sleep? Are you in prone position, lateral? All those type of things would probably be the aspect of really putting together kind of that full gestalt of getting an understanding about where we're at and how would we intervene next.
Yeah, when you see neck patients, how often do you think, let's flip it around. When you see patients that have got headaches, how often do you think that a lot of that is coming from their neck, whether that is posture, whether that is an actual cervical radiculopathy, a pinched nerve, or some other kind of myofascial problem? How often do you think headaches are really influenced by neck issues?
You know, I will tell you, it took me a little bit from a Regenerative standpoint to be able to get a better understanding of how things are interconnected. You know, originally by training, we are very discrete in nature, and I don't mean to typecast any specialty, but for pain, traditionally, we would think about neck for a lot of things because those are things that we can do, right? If you see many neurologists, they may think about intracranial pathology. So what that means is that, is it coming from the brain? Is there a structure that's maybe more ominous that has some other issues that might be causing that headache? But I think at the end of the day, what we really have to do is kind of take this to a much broader scope. And that's one of the ways that we practice now, is to say, okay, if it's head pain, maybe it's coming from the neck. If it's the neck, maybe it's coming from a higher source or a lower source, and really evaluate all those things in full. So that's really the approach now, to be able to make sure that we can give a good outcome and that we can get a good assessment.
I think it's interesting because I hear what you're saying. I know when I first started in practice or through my training, it was much more your problem is X. And as I've sort of progressively gotten more and more involved in regenerative medicine, understanding concepts like prolotherapy and biotensegrity, and realizing that just how many layers of tissue are involved in the musculoskeletal system, and how segment to segment are really influence each other, it's interesting because it really changes your perspective on the musculoskeletal system. And it makes you realize just how interrelated, the top of the spine to the bottom of the spine really is. And someone who's got a headache and, they've got a little bit of asymmetry in their hips or their ankles, like how much does that affect their neck and their head? Like it's profoundly more significant. And I think for physicians, a lot of times we don't necessarily get trained in that regard, but that's obviously an important aspect of how to approach someone with musculoskeletal issues, in particular neck and head. And you made a really good point, which is that physicians look at these things very differently. They have a very different approach. A neurologist maybe focus more on intracranial pathology or a vascular kind of issue causing headaches. And it's a very different approach, and it can be right in some people, but not always right in other people. And it's sometimes hard, I think, for patients to really understand that medicine is not always such a cut and dried approach, that there's a lot more layers involved in this. And it's probably hard for people to really get a sense for, hey, what is Dr. Landrum's approach to treating neck pain or headaches? But that's probably vastly different than maybe somebody else that they could see for neck pain. And if I had to put you on the spot and said, define for me Orlando Landrum's approach to treating spine-related issues in like that 2 to 3 sentence kind of package that kind of really hits home for how patients and other people should sort of think about your approach, give me that sense.
darn good question. This should be spread beyond Facebook and Instagram for that kind of question. So, all right, let's see. 2 to 3 sentences. To me, I think at the end of the day, what I want to make sure that we do in terms of treatment and evaluation is, number one, we rule out serious pathology that's going to make sure that you can be able to have peace of mind and that there's not going to be harm that befalls you. Number two is I want to make sure that your pain and functionality improves through whatever treatment we need to do in order to get there. And I would say in terms of the evaluative process, I think that I use a blend of both musculoskeletal and neurologic evaluation, and then we pair that as needed with imaging to be able to get some clarity about how we're going to treat and intervene.
Yeah, that makes sense. So when so let's say you've come to some kind of diagnostic approach and sort of decide that, okay, here's someone who's got some early degenerative changes in the neck, maybe a little bit of facet arthritis, maybe a lot more kind of myofascial things. Next steps, what are your next steps in treatment at that point? And then how does that escalate as needed?
So what I would say is, originally I used to be like, all right, we know what the targets are, let's go get them, right? We're tip of the spear, let's go get it, right? But now I think it's different, because the question I think that is really critical, and you asked it in a different context earlier, is why? And the piece would be, so why do you have that facet disease? Why do you have that myofascial problem? And the major reason for that is, so let's say that we intervene and we quote unquote fix that problem. How do we know it's not going to be recurrent? So what we really need to get to is, let's ask a few more questions. Let's do a little bit more in terms of exam and understand, is that degenerative course just because it is wear and tear? Or could it be something else that may have caused that we need to address? Because if we don't, it's just like you've plugged a piece of cement in the foundation, but you never figured out that you actually had a sinkhole that was going on. Let's deal with the sinkhole and make sure that we're not missing something else in order to be able to kind of address this.
Okay, so let's say you've taken that step. Give me the next steps.
Okay, so fine, we got facet disease. We know that there's nothing that's ominous. It's kind of general kind of wear and tear. So then the question would be, so when I do cervical hyperextension, can we be able to elicit that pain? Assuming you don't have any whiplash, nothing that's taken place from a motor vehicle accident, anything along those lines. You've been through physical therapy. You've done some of those things to be able to try to see what you can do. And you've tried to do other type of things that have kind of really tie in with physical therapy, meaning you've done things that have tried to address fascial layers, the things that you might have considered maybe doing some dry needling perhaps. Maybe you've done some postural restoration. Maybe you've done some red cord type therapy, all those type of things. Perhaps at home, you've considered doing some things where you've done like inversion table or something along those lines to see if you can get some degree of benefit. Then what we're talking about is seeing, does that facet disease stay right there localized to the axial spine, or do you potentially have some radiation? Because cervical facets can give you radiation into the aspect of the shoulders, into the scapula, those type of things. And if that's the case, then what we really want to do is to try to look at how can we be able to use an orthobiologic type treatment to be able to intervene and give you something that's going to be sustainable. You know, I think many pain docs would have traditionally said, let's do diagnostic blocks, let's maybe use steroids. But the fact of the matter is, what we want to do is to try to get that back to its natural state. And so that's really how we want to go about trying to treat it.
You know, it's interesting. Diagnostic blocks, they make a lot of sense in theory, right? And in some cases, if someone's pain is really truly coming from just that one structure, that makes a lot of sense. But the reality is, it's always more complicated. There's always multiple layers. And so you use the term orthobiologics, great term, right? Referring to a lot of your cell-based treatments, a lot of times your own cells, including platelets or bone marrow-derived stem cells, to help treat orthopedic musculoskeletal conditions. So let's say first-line treatment, have already gone through physical therapy, posture correction, some other basics. What is the first-line orthobiologic you would use for a neck issue?
So, I mean, if we're starting from the very, very basic and we're not even including kind of that biologic piece, I think what fits into the whole spectrum of it is the context of us looking at that aspect of traditional prolo, before we get in. And so that prolo piece has a wide variance, right? So you could talk about traditional prolo. You could talk about whether you have that with the aspect of platelet lysate that's combined in connection. And in that context, what we're talking about is that aspect of the tendons and the muscles and how they relate to the elements of how they connect into the spine. And I think that that's an interesting piece. I think from a facet standpoint that we talked about earlier, when we start looking at that intra-articular components of facet, kind of going from that zygapophyseal joint, that face of that joint are we starting to have some changes in the cartilage that's present there? If that's the case, then we're probably going to step it up a little bit and look towards something that will fit within the model of kind of PRP or platelet-rich plasma. So those would kind of be the two things that we'd kind of be making a decision about in that entry level. And more than likely, it's probably a blend of both.
I got briefly disconnected, but I heard you talk about as an intro level, you're thinking prolotherapy versus platelet-rich plasma. In your experience, when it comes to spine-related things, number one, how do you decide between one or the other, right? Someone who's got, let's say, mild to moderate pathology, how do you decide which one to start treatment with? And if you start with a lower level treatment, in general, how would you approach that? Would you say give it a couple treatments? Would you say give it one, see what happens? What's your general treatment algorithm or approach to that?
Yeah, I think the answer to that, and not to be political and avoid the question, but I will tell you, to me, I think it's very personalized. I think that you have to tailor the treatment to the person, right? So what I might say in one person will not be the fit, even if you have the same clinical presentation. It's really going to be about what's your functionality, where you're at, and what's your mindset to an extent too. So I think we really have to get clarity about all those type of things. But in answering your question, I think, so let's say that this is not making a major impact on your life. Let's say that you say, you know what, it's bothering me. It's a nuisance, but it's not making me have to say I am grimacing in pain consistently. Then it kind of gives us an idea that maybe we start at a low level. And then we see how that works in conjunction with things that you are doing autonomously, meaning your own exercises, influencing your kind of biopsychosocial level of things that surround you. Can you change your pillow? Can you change your sleeping habits? Can you do other things to be able to improve that? And then see how we're able to step it up. If someone says that, you know what, I am in debilitating pain, I can only sleep maybe an hour, a night, I can't be able to function at my job, I have, just deficits that are causing me all types of problems, then we look to potentially scale that. If someone's had this problem for a number of years and then like, I've tried everything, I'm tired, let's see what we can do to be able to intervene, then that's how we're going to kind of look towards what that scale happens to be and how we would be able to treat.
Yeah, that makes so much sense. That it's never going to be a hammer hitting a nail kind of approach. It is always going to be such a personalized, individual based approach based on goals of the patient, based on degree of pathology, what have they tried, how limited are they, and all their other kind of medical issues always has to be considered as well. Okay, cool. Okay, so then, so we've talked a little bit about prolotherapy, platelet-rich plasma, platelet lysate. Give me a sense for when you would actually escalate to even something stronger, like let's say bone marrow aspirate concentrate or bone marrow-derived stem cells.
Yeah, so I think when we talk about neck pain, we haven't talked about, or at least I haven't talked about in depth and detail, what are some of the pathology. Let's say we move muscle aside and we'd say it's not facet. You can have cervical radiculopathy, which can be caused by a number of different things. It could be caused from a herniated disc. It could be caused because you have a foraminotomy, or rather the foramen is actually decreased in size. Perhaps you have some degree of cervical instability that causes you to have a shift and have other problems that's in place. It could be ligamentous in nature. It could be discogenic, meaning it's within the context of the disc itself. So, and outside of that are things that would be more neurologic. So you could have a brachial plexus component, you can have cervical plexus issues, you can have occipital neuralgia, all those type of things all have an interplay between the head and neck component that give you things that you need to really kind of assess. So when we talk about looking at the aspect of bone marrow concentrate as a potential utility, really where I kind of see it having a great fit is when you have severe facet disease or when you have disc issues that need to be addressed. Can you be able to deal with it from looking at utilizing something called platelet lysate, which is similar to PRP that has a different variant and form to target and be able to surround the nerves and give a much more robust but less caustic response than traditional PRP? Yes. But when you talk about looking at intradiscal and facet pathology, which is severe, sometimes it doesn't respond to just PRP. It doesn't respond to platelet lysate. And at that point in time, then you're talking about using a more aggressive treatment in order to be able to get a much more improved therapeutic response.
Yeah, that makes a lot of sense. I love how you originally address it by saying, look at all these other structures as well, right? Meaning that the layers and layers involved in terms of treating this is very rarely just, hey, you have a disc problem, or hey, you just have a facet problem. It's all those other layers that kind of drive things as well. I remember learning this concept when I first got involved in regenerative medicine. I didn't have that full understanding of biotensegrity and prolotherapy. I looked at it in a very linear fashion. And one thing I learned from some of those old school prolotherapists, and he's not going to be happy that I'm calling him old school prolotherapist, but Tommy Bond. But he has his concept, he's based out of Louisiana. He has his concept of like Cajun prolotherapy, where he's treating different layers of tissue throughout that whole process. And I'm not exactly sure what's Cajun about it.
That's
But
what I
the point
wanted
is,
to know.
I don't know. That's his style. But the idea that he's hitting all those different layers that are causing that kind of weakness from a biotensegrity standpoint, strengthening that whole structural unit, is a really interesting idea. And the longer I'm sort of involved in this field, understanding that prolotherapy really does work from skin all the way down to the structure that's been damaged. It's a really kind of smart and bright way to approach that. Okay, so tell me more about neck pain and headaches. I think headaches are a humongous problem in society. And a lot of times they're just treated with that sort of pharmaceutical approach that typically helps more with just either masking pain or sort of vascular related pain. Give me your approach to how you're looking at headaches, if they are related to any of those peripheral nerves that are coming from the neck or from the neck itself.
Yeah, so I think your commentary about headaches are spot on, because traditionally, the way that we try and treat many problems, particularly when they have a pain focus, is to say, what medicine can we give? And I think that has a number of flaws, as we've kind of talked about in our conversation already, because to kind of maybe not use a Cajun analogy, but to go a different way that's describing this similar perspective, it's not a portfolio that you want to have. But to me, it's kind of almost like you have a portfolio of things that present themselves. Meaning, so you don't just have one problem, but you have a multiple different problems that might exist, and they're different percentages that you have invested in different areas, right? So it could be that you have a disc, you have a facet, and then you have an occipital nerve problem that all contribute towards your problem. The question is what can you impact the most in order to be able to get the best return, right? So when we talk about going to headaches and such, it's really convoluted, or at least it can be, and I think that first and foremost, it has to be where the physician and patient feel comfortable to be able to talk freely. And I know that sounds like a lot of fluff, but for me, I don't think that's the case at all, because headaches has a whole host of connotations that are associated with it, where people feel like there's a bit of malingering. Or are you really having a headache? How bad can it be? I'm sure it's not that debilitating. Maybe you just need to be a little bit more stoic, or you just need to kind of suck it up a little bit. And particularly when you've been to more than one doc, sometimes you kind of feel like, man, I don't want to be a complainer. I don't want to be a whiner. And right from the very beginning, we want to toss it out the door. We need for you to be able to feel like you're comfortable in order to explain what's going on with you, so that we can really get down to the nuanced piece of like, what's the challenge that is bothering you or that's annoying you, and how can we tease that out to be able to get a better understanding about things.
Yeah, that makes a lot of sense. Go ahead. Sorry.
That's all right. So when we talk about looking at headaches, there's a huge component that can be everything from us, number one, is there an intracranial issue, which more than likely is not the case, to the most common being, is it tension type headache where you have a muscular imbalance that's causing you some problems and issues? That can come from the neck, can come from the head, right? Could it be an occipital neuralgia type issue where you have nerves that are present in the back of the head and neck that really are giving you a problem with pain type sensation that goes from the back of the head over to the front? Is it a cluster phenomenon where you have an issue where you have a problem with the aspect of the eye, which is classically described as like an ice pick, where you have just this lancinating, burning pain that's present within the context of the eye? Could it be coming from something like trigeminal neuralgia? Could it be coming from something like sphenopalatine issues? Things where there are foci and collections of nerves that exist in the cranial nerve component that exists in and around the skull that we can be able to treat. So those are things that are kind of the quote unquote common things, but there are other elements that could be in place. Are we looking at a dental issue? Could you have bruxism where you really have a bad fit with how your teeth are and you kind of chew or grind at night and you really need to kind of see what's going on with the jaw? Do you have TMJ as a potential option as a potential issue? So all those things really need to be kind of evaluated in full and then said, where do they fit in that portfolio? What's the percentage of where they're at based on history, physical, as well as the likelihood of debilitation, and then say, how can we be able to intervene?
Yeah, that makes sense. Very good. There's never a simple one-step answer, right? And so there's a lot of nuances to this, which comes through when you describe your evaluation process. When it comes to using an orthobiologic treatment, how do you like to treat some of those little pinched nerves in around the head in the peripheral area? How do you like to treat those?
Sure. So I'm going to go backwards to come forwards. So I would tell you, by traditional training, the things that we would do before is to do all diagnostic, like we talked about before, right? The problem with doing a diagnostic blockade is that we expect that there's going to be complete obliteration so that we can pat ourselves on the back and say, hey, you know what? We gave local anesthetic. It's better. This was the area. But first of all, maybe the area that you gave whatever that fluid wasn't as specific as what you thought. How did you evaluate it? Did you use ultrasound to be able to give that injection, or did you do it blindly? And I think having had the experience and exposure now to be able to see how refined and exacting you can really be with ultrasound is giving me a different perspective of, let's see where we're injecting and making sure exactly what we give goes to the spot where we need for it to go. So that's one. But two, I would say traditional pain treatment would say, let's do neuromodulation. Let's think about doing maybe peripheral stem. Let's think about doing spinal cord stem and see how those nerves can be able to respond. But again, if I had my druthers and it was me, and it was a family member, what I want to say is, can't we correct the nerve and get it back to the way that it was before we talk about adding another stimulus to try to change it? So the things that we would use currently in order to be able to do this is something like platelet lysate, where we can be able to say, how can we give an injectate that's really going to give a good response to that nerve, get that nerve back to a functional status of how it was originally, and get it back to not only giving you the sensory information, but hopefully it acting in concert with things that work from a functional standpoint.
Yeah, that's wonderful. That makes a lot of sense. I think especially when you put it into the context that you're treating not only the nerve that may be pinched or damaged with an orthobiologic that is actually healthy for the nerve, but then you also take it to the next level where you're treating those other layers that may also be not only driving pain, but may have some component of weakness, where from that standpoint of strengthening those other supportive tissues goes a long way to support the nerve health as well. The deeper you get involved into something like that regenerative medicine approach, the more nuanced you realize it is, and the more you realize that hitting all those other adjacent supportive structures is sometimes as critical. And it's the kind of stuff that a lot of times gets ignored, but a lot of times not only does that sort of drive more pain when you're actually injecting that kind of soft tissue structure, but just at least the philosophical sense that that's what supports the actual structure or tissue that's damaged, goes a long way, I think, to getting people better longer term as well. Orlando, I appreciate your time. We're getting toward the end of our time here today. Any last thoughts about headaches, neck pain, COVID-19, life, telemed, tech? We covered a few different things. Any other thoughts before we call it a day today?
I think the thing that really is standout is that we've been able to have kind of that partnership where we've been able to work together. And I can be able to bounce ideas off of you, and you can do the same. And we can be able to provide, that value to patients in general about being able to give them a full, comprehensive evaluation that takes into account things that I don't think many practices have. To be able to kind of have both a rheumatologic as well as kind of a traditional pain perspective, and then bring that in the context of regenerative medicine, I think is very rare and is quite unique. And to be able to provide that in the context of the total body of the person, I think it's an offering that is incredibly valuable. And I hope that we can be able to help a lot more people in that context.
100%. I agree with you. I value the collegiality. I value the collaboration. I value the learning, right? I think that's fantastic. And I think that leads to better patient care long-term as well. So thank you very much again.
Thank you.
Great. Look forward to talking in the future. And for watchers, listeners, thank you for your time. If you have questions or would like to learn more, you can contact me at chicagoarthritis.com. Orlando, Dr. Landrum is available all over the internet as well. Orlando, if you want to kind of mention your where people can contact you as well, please let us know.
Yeah, you can go to cuttingedgepain.com. And then from there, you can find a way to be able to connect to our YouTube channel or our newsletter.
Great. Thank you, everyone. Have a good day and live well. Bye-bye.
All right. Take care. Bye.